Hey, welcome back to the pharmacology session. Today, we are going to conclude our journey into pharmacodynamics. We are going to explore some advanced but essential concepts like spare receptors, how our cells adjust to the drugs, why people react differently, and the complex world of drug interactions. Get ready to have your mind blown by sheer sophistication of your own body. Okay, let's start from spare receptors. More than meets the eye. Okay, last time we used the analogy of a car and a driver. You might think that to get the car going at maximum speed, you'd need a driver in every available car. But that's not always true in the body. Spare receptors exist when a maximal drug response can be achieved by occupying only a fraction of total available receptors. You don't need to fill up every single parking spot to get full effect. Imagine a huge parking lot for a concert venue. You only need to fill up, say, 20% of the parking spots for the concert to be completely sold out and for the venue to be at its maximum capacity. The other 80% are spare. Spare receptors mean that a drug can achieve a maximal effect even at low concentrations or when many receptors are lost due to disease or blocked by antagonists. It enhances the sensitivity of the system to the agonist and allows for rapid, robust response to small amounts of the ligand. This is crucial in many physiological systems like in cardiac muscle where a small amount of adrenaline can cause full contraction. Cells adjust to the drugs. So our cells are incredibly adaptable. They don't just passively receive drug signals, they effectively adjust how they respond over time. So this is called as receptor regulation. Think of a parent telling a child to do something. If the parent keeps nagging, like the constant drug exposure, the child might start ignoring them. That is, they get desensitized or even hide in their room. That's the down regulation of receptors basically. Conversely, if the parent is absent for a long time, like the prolonged antagonist exposure, the child might become extra eager to listen when they finally return. That's supersensitivity or upregulation. So let's get deeper. Desensitization and tachyphylaxis. Desensitization is a regular term for decreased responsiveness to a drug, often occurring over minutes to hours. Tachyphylaxis, a very rapid form of desensitization where responsiveness diminishes quickly after a few doses. Often involves the phosphorylation of the receptor or change in its conformation, making it less able to signal even when the drug is still bound. Patients using nasal decongestant spray like oxymetazoline frequently experience tachyphylaxis. After a few days of continuous use, the spray becomes less effective, leading to rebound congestion as the nasal receptors become desensitized. Then we have down regulation. A decrease in the number of receptors expressed on the cell surface, usually due to prolonged exposure to an agonist. The cell literally pulls receptors off the surface and internalizes them, making them unavailable. Chronic exposure to opioid pain medications can lead to downregulation of opioid receptors, contributing to tolerance. Upregulation, so basically an increase in number of receptors, often in response to prolonged exposure to an antagonist or even lack of a natural ligand. The cell makes more receptors, pushing them to the surface. If a patient is on a beta blocker for a long time and suddenly stops it, the heart cells which have upregulated their beta receptors can become hypersensitive to the body's natural adrenaline. This can lead to a dangerous surge in heart rate and blood pressure known as beta blocker withdrawal syndrome. So, variability in drug responsiveness. Why we all act different? We're all unique and so are our responses to the drugs. The average dose often isn't perfect for everyone. Significant individual differences in drug responses exist due to various factors. Imagine trying to fit the same glove on everyone. Some hands are too big, some are too small, some just right. So reasons: genetics, disease statuses, age, weight, idiosyncratic reactions, tolerance, cross tolerance, and placebo effects. So genetics we know, and disease states like diseases can alter receptor numbers, binding affinity, or signaling pathways. Like in heart failure, beta receptors can be downregulated, and age and weight. So, and then we have idiosyncratic reactions. These are rare and predictable drug reactions that occur in a small subset of individuals, often due to genetic predispositions, and are not dose dependent. Like a car randomly changing color after a specific type of fuel. Ooh, weird. Decreased responsiveness to a drug with repeated administration, requiring higher doses to achieve the same effect. So the tolerance is increased. And cross tolerance is basically tolerance to one drug confers tolerance to other drugs in the same class or with similar mechanisms. And placebo effects, a physiological or psychological response to a drug based purely on expectations and not its pharmacological properties. That's the power of belief. And antagonism and interactions, drugs playing together or not. Drugs rarely act in isolation. They can interact with each other, sometimes beneficially, sometimes dangerously. Pharmacodynamic antagonism. This is when two drugs acting on different receptors or pathways produce opposite effects. One person pushes a car forward and the other pushes a different car backward. So, histamine causes bronchoconstriction, whereas adrenaline causes bronchodilation. Giving adrenaline is a physiological antagonist to histamine is an allergic reaction. So that's how it works. Allosteric modulation. This is a subtle but powerful interaction. Imagine a car with main ignition keyhole, that is the active site. An allosteric modulator is a secondary switch on the dashboard. It doesn't start the car itself, but it can change how well the main key works, either making it more effective or less effective. A drug binds to the receptor different from the active site, altering the receptor's conformation, thereby changing its affinity to the natural ligand or agonist, altering the efficiency of the bound agonist. So the best example is benzodiazepines. So these are allosteric modulators of GABA receptors. They don't directly open the chloride channel, but they bind to the separate site, making the receptor more sensitive to GABA, increasing the frequency of channel opening and thus enhancing GABA's inhibitory effects. Drug-drug interactions at receptor or signaling levels. When multiple drugs are taken, they can compete for the same receptor or interfere with each other's signaling pathways, leading to altered effects. So, combining two drugs that both cause central nervous system depression, like alcohols and sedatives, can have a synergistic, dangerously amplified effect. Clinical conditions and examples like, so why is this all intricate detail important for from a clinical perspective? So, beta blockers, opioids, steroids, they are really important. Beta blockers like metoprolol, we discussed their use in hypertension. So long-term use can lead to upregulation of beta receptors. If a patient suddenly stops taking beta blocker, they can experience a dangerous beta blocker withdrawal syndrome, tachycardia, hypertension, angina due to low hypersensitive heart responding strongly to adrenaline. And then we have opioids. Chronic use leads to tolerance, often involving desensitization and downregulation of opioid receptors. So this is a significant challenge in pain management. Steroids, long-term use of systemic steroids leads to suppression of body's natural adrenaline steroid production. Abrupt withdrawal can cause adrenaline insufficiency due to the body's own system being downregulated. So these allows clinicians to anticipate patient responses, adjust doses, manage side effects, and safely guide patients through complex therapies. And that is it.